Now we come to the main section of tissue nematodes. I'm with you, Dr. Magda Elnazer, again, and we'll study this time the filariae. The filariae or filarial worms all are transmitted through arthropod vectors in which the worm has a part of its life cycle, and these arthropod vectors have to suck blood containing the microfilariae, which is this stage, and also this one, and also this one. These are several types of microfilariae of the filarial worms infecting men. The adults are long thread-like nematodes inhabiting lymphatic, subcutaneous, or deep connective tissues. Some are purely human parasites and some may infect animals also. Females produce eggs in a special elongate form, the microfilaria, which is present in blood. They are viviparous. Microfilariae develop into larval stages when ingested by insect vector during its blood meal, and the infective third stage larvae, which eventually occur in the insect vector, they are deposited from the mouth parts of this insect vector on the skin when the vector takes the next blood meal. They enter the body through the bite wound made by the insect. This is larva 1, or the first stage of larvae. This is the third stage larva, and this is the insect vector taking the blood meal. And this is a picture of microfilaria. It is a thin, tiny stage with anterior end here. You see in the anterior end something like a stylate or penetration apparatus. Here is the posterior end of the microfilaria, and this is important in differentiation between them in a blood film. And the body is filled with several nuclei. The first and the most common of these filarial worms is Wuchereria bancrofti. Wuchereria bancrofti causes bancroftian filariasis, and the disease is widely distributed in tropics and subtropics. Morphology and life cycle. The vector is Culex, Aedes, and Anopheles, all types of mosquitoes present according to the locality. In Egypt, Culex is the vector of Wuchereria bancrofti. In the Far East, Anopheles is the vector, and Aedes also in the Far East and in Africa. Mosquitoes ingest microfilaria during blood meal, as we said before, and the microfilariae transform into the first larval stage inside the stomach of the insect, penetrates the stomach to migrate and settle in the thoracic muscle of mosquito to form the second larval stage, and the third, which crawls anteriorly to the mosquito mouth parts or proboscis to settle there, remaining and waiting for the next blood meal. This occurs within 10 days from the previous blood meal. During the next blood meal, the larvae escape from proboscis to enter the human body through the bite wound made by mosquito. Not they are injected into the body by the mouth parts. This is the life cycle of Wuchereria bancrofti, and we find here this is the bite and where the mosquito takes the blood meal here from the patient, taking the microfilariae. This transforms into the first stage larva, then the third stage larva forms to settle in the mouth parts of the mosquito. The adults, you see, the female is more and much larger than the male, and the adults produce sheath microfilariae. They settle in the large pelvic lymph nodes and also maybe in the thoracic lymph nodes sometimes, and axillary nodes to stay there in the big lymphatics and lymph nodes. In the human body, the larvae reach lymphatics. The regional lymph nodes and large lymphatics are their habitat. They molt to adults and produce microfilariae. The adults are thread-like, males about 2.5 to 4 centimeter and females about 5 to 10 centimeter by 25 millimeter. Sorry, by 0.25 مليمتر، يعني 2 مثلا أو 3 سنتي في ربع سنتي. The microfilariae are 300 micromillimeter long and have redundant sheaths around. The body contains distinct nuclei and the pointed tail end is free of nuclei. This is important for characterization of Wuchereria bancrofti. This is an adult female. This is an adult male with special posterior end here. And this is the microfilariae with the sheath as we see here and here in the anterior end, and the tail end, which is the space from here to here, is devoid of nuclei. In endemic areas, it is known by nocturnal periodicity, meaning that the microfilariae appear by night. There is subperiodic form in the Pacific Islands where microfilariae are present all day but reach the peak from 2 to 8 p.m. It is suggested to be separate species called Wuchereria pacifica, but till now it is a type of Wuchereria bancrofti which is subperiodic. The cause of periodicity is still not clear. The microfilariae are best seen by night from 10 p.m. till 2 a.m. at night, but they are present from 8 p.m. till 4 a.m. It is suggested that microfilariae go to the lungs during day as there is high oxygen tension than in the peripheral circulation. Also, they they can um, uh, relate the periodicity to the sleeping rhythm of the patient, as when sleeping rhythm is inverted, microfilariae inverse periodicity. Also, they related to the periodicity of mosquito bites, because when mosquito bites bite patient by day, they are day feeders, the microfilariae appear in blood by day. But till now, they didn't settle on any of these causes. Pathogenesis of lymphatic filariasis. Adults are mainly in the axillary, pelvic, and inguinal lymph nodes, also in the large lymphatics distal to them, and lymphatics of male genital system. This is important and characteristic for Wuchereria bancrofti. The main pathology is the inflammatory changes around the adult worms, which are caused by immune response of the patient. This inflammation of inguinal or upper limb lymphatic vessels and lymph nodes causes retrograde lymphangitis. Retrograde lymphangitis, in case of scrotal lymph nodes, there is orchitis, epididymitis, and funiculitis also. In case of abdominal and pelvic lymphatics, there is systemic manifestations of fever without inflammatory localization. This is called elephantoid fever. Repeated lymphangitis causes fibrosis of these lymphatics, thickening and dilatation, then occurrence of lymphedema due to their obliteration. It is transient firstly, but becomes permanent by time. Chronic lymphedema causes thickening of connective tissue, induration, cellular infiltration, thickening, and verrucous changes of skin ending in elephantiasis, or the skin looks like the skin of elephant. Elephantiasis occurs in any limb and in scrotum, rarely in vulva and breasts of the female, disfigurements and sometimes disabling, usually accompanied by secondary infection. Early hydrocele may occur. Subcutaneous dilated lymphatics may rupture, so there is lymph scrotum. Dilated lymphatics in the urinary bladder may rupture, causing chyluria. The urine contains lymph, so it looks whitish color. The clinical picture and symptoms. Early manifestations are fever, lymphangitis, lymphadenitis, which we call filarial or elephantoid fever. Lymphangitis occurs centrifugally, and there is surrounding hyperemia and edema. Lymphadenitis occurs when lymphangitis or may occur alone. It is in inguinal and epitrochlear nodes. Epitrochlear is more in the subperiodic filariasis than in the ordinary filariasis. Scrotal involvement may occur early with edema of the scrotum. Lymph may also collect in scrotum, causing lymphocele. Microfilariae can be found in the scrotal fluid if lymphocele occurs. Lymphatic rupture into the urinary tract may cause chyluria, and the microfilariae can be found in urine in this case. Elephantiasis occurs as a late complication of the disease, and it is reversible. Here is a picture of someone with the lymphatics, and it makes what we call draining of lymphatics by some sort of um, blood uh, donation tube, as you see, and he is taught to make it by himself to relieve edema. There is another one in the other picture here, also having lymphedema unilateral. In this case, a female is disabled, as you see, because she has to do her home activities while sitting on a chair. This is the picture of urine with lymph, what we call chyluria. Occult filariasis is an issue called also tropical pulmonary eosinophilia or Meyers-Koehner syndrome, lymphadenopathy, lung infiltrates, splenomegaly, and hypereosinophilia. These are cases of hyperimmunity to microfilariae. The cases are diagnosed on basis of the clinical finding, elevated immunoglobulin E, eosinophilia, as well as improvement with antifilarial therapy. There is high antifilarial antibody titer in the serum. Also, it is caused by both Wuchereria bancrofti and Brugia malayi, the next filarial worm, and it can occur to people coming to endemic areas. Diagnosis of filariasis. This is by having the characteristic clinical findings, and these are well known in the endemic areas. Usually filariasis is focal and endemic and not spread all over like any other infectious disease. Also, we must find microfilariae in fresh and thick blood films. Also, we can do provocation to these microfilariae if we don't want to fetch them by night, for their nocturnal periodicity is inconvenient to the patient. So we can do provocation to detect nocturnal infection during day, but this does not affect the subperiodic type. The subperiodic type also is easy to be taken by 2 to 8 p.m. Also, we can do nucleopore filtration of 5 millimeter blood by day, and we can find few microfilariae. Also, we can do skin test with antigenic extract from the dog filaria, Dirofilaria immitis, which is similar and antigenically nearly similar to Wuchereria bancrofti. Other serological tests like indirect heme agglutination, indirect fluorescent antibody test, and ELISA detection of filarial antigens and filarial antibodies can detect infection, saving patients from the complications of the disease. Treatment: antihistaminics and aspirin can treat lymphangitis. Diethylcarbamazine, DEC, or hetrazane or filaran, it affects the adults, but it has no microfilaricidal effect. Another drug, ivermectin or mectizan, affects both adults and microfilariae and can be given in a single dose. But usually now they give combination of diethylcarbamazine and ivermectin as a treatment because of the resistance to these drugs. Surgical treatment is successful only in scrotal elephantiasis, not in the limbs. So the effect on the limbs or the elephantiasis of the limbs is irreversible, as we said before. Steroids can be used in conjunction with bandages to lessen limb edema, and this is the case in case of treatment of the limb edema. Now we come to Brugia malayi, which is the Asian type of lymphatic filariasis. The life cycle is similar to Wuchereria bancrofti, and the main vector is Mansonia and Anopheles. Mansonia is also from the tribe of Culicini, like Culex and Aedes. Monkeys and wild cats are reservoir hosts for Brugia malayi. Microfilariae are sheathed and differ from Wuchereria bancrofti by having two nuclei extending to the tip of the tail, and they have diurnal periodicity. This is the microfilaria of Brugia with the two nuclei here. Also, this is pictured with phase contrast microscopy. Here is the anterior end. Here is the posterior end, and these bulgings are for the two nuclei. Enlargement doesn't affect really the picture, and we must go to the next slide. Clinical features are nearly similar to bancroftian filariasis. There is lymphangitis, lymphadenitis, and filarial or elephantoid fever, but hydrocele is rare. Elephantiasis occurs below the knee only, and elbow doesn't extend above the knee like that of Wuchereria bancrofti. Chest X-ray can show pulmonary nodules which may contain the parasite or the adult worms. Treatment is same as bancroftian filariasis, and diethylcarbamazine in this case kills both adults and microfilariae of Brugia malayi, but in case of Wuchereria bancrofti, it kills the adults only. This is a case of Brugia malayi. You see how the leg is usually affected, but only to the level of the knee. Also, this is another case with severe elephantiasis, but it doesn't extend above the knee also. Brugia timori is a special species present in Timor Island in Indonesia. The disease is closely similar to bancroftian filariasis, but there is high rate of inguinal abscess formation with death of the worms in the inguinal lymph nodes. Microfilariae appear, and they differ from Brugia malayi in being longer and that the cephalic space anterior to the nuclei is longer also. They have nocturnal periodicity, not diurnal periodicity as Brugia malai. The vector is Anopheles and humans are the only host. Now we come to Lua Lua, what we call the African eye worm. This is called so because it doesn't exist in the world except in tropical Africa. The infection by adult is very obscure because the adult usually migrates in the subcutaneous tissue, including subconjunctival area, so can appear crossing the eye or the nasal bridge. The adults are about 2 to 7 centimeters long and the female is longer than the male, and both are 0.2 centimeter in width. Microfilariae are sheathed present in blood, and the body nuclei fill the tail end, and this is characteristic, not like those of Wuchereria bancrofti, and where the tail end is devoid of nuclei. This is the picture of the microfilaria of Lua Lua, and we can see here this is the posterior end is dark in color because it contains nuclei till the tip of the tail. The life cycle of Lua Lua is similar in outline to that of Wuchereria bancrofti because there is a human stage and the fly stage, but the fly here is called genus Chrysops. Genus Chrysops, or the deer fly, is the adult, this is the vector of Lua Lua, and it is present only in Africa. It is a big fly, colored, and it is present in the forests of the rainforest in Africa. It is a blood-sucking. The female only is blood-sucking, and when when it sucks blood with the microfilaria, we have then the development to first stage, second stage, third stage larva, the same as in Wuchereria bancrofti, and the adults here, as we know, present in the subcutaneous tissue, giving birth to microfilariae which pass into the circulation. Circulating microfilariae have diurnal periodicity. When ingested by the vector, which is Chrysops or deer fly as they say, they develop within the fly the same as in Wuchereria bancrofti, and infection occurs also in the same manner. Adults don't produce pathology due to their rapid migration, and there is high eosinophilia and high immunoglobulin E levels. Migration of the adults is painless and seldom seen except over body prominences or bone prominences and nasal bridge, or in the subconjunctival area, but sometimes they produce edema in the eye during crossing, like in this case. Sometimes the adults produce localized subcutaneous swelling called Calabar swelling or fugitive swelling because it appears in some place and disappears in the other in the body. This is preceded by pruritus and lasts for several days. It is an allergic reaction to the worms and it occurs usually to the tourists and immigrants to the endemic places. Ectopic filariasis can produce hydrocele, occlusive colonic lesions, glomerulonephritis, and fibroblastic endocarditis and retinopathy. This occurs when the adults migrate and settle in the organs. These are rare and occur in patients in endemic areas. Also, tropical eosinophilia or a microfilariamic filaремia also can occur with loiasis like that in Wuchereria bancrofti. Diagnosis is by finding the characteristic microfilariae in blood film. Clinical diagnosis by history of Calabar swelling or the adult seen in the eye can aid in diagnosis. Treatment by surgical removal of the adult when present in the eye. Also by diethyl carbamazine, which is effective but risky in heavy infections as mass destruction of microfilariae in the brain capillaries can cause fatal encephalitis. Ivermectin is also given in heavy infections more safely than diethyl carbamazine. Diethyl carbamazine, not carbamazine. This is an operation of removing the adult from conjunctiva. You can see here the adult in the subconjunctival, the adult here in the subconjunctival tissues, and the doctor had made a tiny incision here and pulling the adult worm outside the eye.